This patient has outgrown her right ventricle to pulmonary artery conduit, which requires changing. With the patient in the supine position, the operation is approached through her old sternotomy wound. As her heart is likely adherent to the internal structures of the chest, and we will be operating using diiatherrmy, external defibrillator paddles are placed on the outside of the chest, as seen here. This is the apical electrode, named for its position over the apex of the heart. Out of sight to the patient's right-hand side is the basal electrode. Its very edge will be seen later, far out to the right-hand side of the patient. With the electrodes in this position, when the defibrillator is discharged, the current will travel through the muscle of the heart from the base to its apex. The incision is made through the old sternotomy scar, marked here for clarity. The location of the suprasternal notch is noted. Scarring and adhesions present in and around the old sternotomy may require an initial incision that is slightly longer than is normal. This gives room for better exposure and later allows us to distract the two halves of the sternum without excessive tension on the tissues inside. The distal edge of the basal defibrillator electrode is seen here. Most of its surface wraps around and behind the patient, to the right of her spine and below the level of the scapula. Prior to incision, the skin of the patient is prepared with chlorhexidine in the first instance, followed by povidone iodine. Off-screen, the skin over both the patient's groins is similarly prepared. The area around the surgical site is draped. And finally, a disposable adhesive surgical drape is placed on the patient's chest. The patient's right groin is explored. The right femoral vein is sought as an alternate source of venous drainage in case the right atrium cannot be safely accessed. The skin overlying the old sternotomy scar is incised. The incision is deepened with diatherrmy along its entire length to reach the front of the sternum. The bottom corner of the wound extends to just below the level of the xiphisternum. The steel wires that were previously used to close the sternotomy are untwisted and left in place. The wires will be later used to help us gauge the depth of dissection when dividing the sternum with a saw. The sternum is divided with an oscillating saw. The lower sternum is retracted sideways and forwards with a pair of retractors in the soft tissue in front of the sternum. The oscillating saw is used to divide the anterior table of the sternum. The posterior table of the sternum is then divided from below upwards. The old sternal wires are then removed. There remain a few places where the posterior table of the sternum is incompletely divided. The saw is gently worked within these areas until the two halves of the sternum are completely separated. The adhesions behind the sternum on the patient's left-hand side are released from below upwards. And the same process is repeated on the right-hand side.